Okay, so the chest, that's the whole point of this module, learning how to take chest x-rays. So let's take a look at what we need to know about. There's three categories of things that we'll find in the chest. We have the bony thorax, the respiratory system, and the mediastinum. So it's the first way to do this is, because it's going to get complicated, you need to learn the first three divisions. The bony thorax is the protective part of the chest. It's the protective framework. We'll talk about the bony thorax. We'll talk about each of these separately, so let's just get them down. Bony thorax. The respiratory system includes the lungs and airways. And the mediastinum refers to the space between the lungs. What's between the lungs? There's a bunch of stuff, but what's maybe the biggest thing between the lungs? The heart is there, but the biggest, right? But then there's also the trachea, there's the esophagus, there's all the great vessels, there's the thymus gland, right? So a number of things in the mediastinum, but the name mediastinum is what we'll call the space between the two lungs. Okay. So yeah, when we look at a chest x-ray, we're looking at soft tissue, right? Lungs and airways and hearts and other stuff. We're also looking at the denser bony framework too, okay? We get to see all of this. Now the purpose of chest x-rays is the heart and the lungs. Let's talk about the bony thorax first. The bony thorax, your thoracic cage, consists of the sternum, clavicles, scapulae, 12 pairs of ribs, and 12 thoracic vertebrae. Let's back up. The sternum. The sternum is your breastbone. It's a flat bone made of three pieces. The top is the manubrium. You can feel the top of your sternum. That's this little notch right here, kind of right where your scrubs, your V-neck of your scrubs come to a point, right there at the top of your sternum. And the bottom of your sternum, called the xiphoid process or xiphoid tip. You can feel where your ribs kind of come together, where they come to a point. That's your xiphoid tip. The rest of it's just the body. So manubrium, body, xiphoid. And we see that here in this image. Manubrium, body, and xiphoid, our sternum, or breastbone. You have clavicles, left and right clavicles. The clavicles are part of what we call your shoulder girdle. We do specific radiographs of the clavicles and shoulders separate. These are separate things, but they're part of the bony thorax. You see them on every chest x-ray. The clavicles have the job of pushing outward, where all the muscles of your chest attached to your shoulder want to pull things inward. So it's this counteracting force, which might explain why the clavicles are pretty commonly broken. Okay, so they take on a lot of force. They're really good about pushing this way. They're not so good about handling forces coming this direction, which is why clavicles tend to break when you run into things or get struck on the clavicle. Also known as your collarbones. Scapulae are your shoulder blades. Scapulae are one of three parts of your shoulder girdle. Your shoulder girdle is your clavicles, your scapulae, and your proximal humerus, the upper arm. Scapulae are your shoulder blades, though. They are also a large and flat bone. Now, the thing we want to know about the scapulae for chest x-rays, we want to get them out of our way, okay? Which is why if you've ever done a chest x-ray, you know that we have the patient put their hands on the hips and roll their shoulders forward to roll the scapula out of the way, right? Shoulder blades. They're a bone. We want to get those bones out of the way. 12 pairs of ribs attached to 12 thoracic vertebrae. We name our thoracic vertebrae T1 through T12, and something special about each of them is each thoracic vertebra has what we call articular facets. They have attachment points for ribs. Ribs attach in the back. Ribs do not attach by bone in the front to anything, okay? The only bony attachment for ribs is posteriorly. In the front, your ribs attach to your sternum, but not bone to bone. It's bone, cartilage, then more bone. Okay. In the back is where you have your bony attachments, ribs attached posteriorly to your vertebrae. 2 ribs for each vertebra. Okay, the next thing is we'll need to get familiar with some basic positioning landmarks on the body. We use these bony landmarks because bones pretty much stay in one spot, right, in the body, and we want to use them to find other, to find our center, things like that, okay? So 2 bony landmarks for the chest that are important. There's a few, but 2 that I think are the most important. First is the jugular notch. I showed you that already. That's the top of the sternum. Oh, yeah, top of the sternum, sorry. And then in the back, you can kind of feel just at the base of your neck, you got this little hump on the back of your neck, okay? Just above your shoulders, right? That's your vertebra prominens, okay? So let me come over to my spine over here. You guys can all just turn your heads for a second. In blue is the thoracic vertebrae. In this lightish purple are the cervical vertebrae, okay? This bottom cervical vertebra, this one here, has a longer spinous process. The spinous processes are all these protrusions sticking out here. Well, this is cervical vertebra 7, and its spinous process is the longest of the cervical vertebra. And if you poke at the back of your neck, that's what you're feeling. If you're feeling this spinous process from C7, it has a special name, vertebra prominens. Okay? Vertebra prominens marks the top of the lungs. This shown in this kind of grayish color are representing the lungs. Look how high up the lungs go, okay? The apices, which are the name for the top of the lungs, go above the jugular notch and go up into what you call like your trapezius muscles up here. They go above your collarbone. Vertebra prominens marks the top of the lungs. So if you have your radiation field, your light field, projecting above the vertebra prominens, then you know you have light above the lungs. You know you're going to include the top of the lungs on your chest x-ray. Now, if you find the vertebra prominens and move down about 8 inches for males, about 7 inches for females, you will find the middle of the thorax, mid-thorax or thoracic vertebra number 7. Now, no one uses a ruler, okay? What we do is we use our fingers, pinky and thumb, okay? You stretch out your pinky finger and thumb as far apart as they can go, and it will be close-ish to 7 to 8 inches, okay? You should know how far this is on yourself, okay? That way you can use it as a measuring tool, okay? Pinky up here, let your thumb fall down. Where your thumb falls should be mid-thorax on most average, normal-sized adults, right? If they're extra small or extra tall, then you have to adjust a little bit more. But on the average person, everyone in this room, right, we're all going to use that same basic positioning. We would on any of you. Okay, that's from the back. The most common chest X-ray is a PA. So in PA, they're touching the board with their chest, right? So their back is facing a way you can get to their back. Now, if you happen to do an AP chest X-ray with the back against the board, you can't touch the vertebra prominens because it's against a board, right? But you do have access now to the sternum, okay? Notice how the sternum, or the jugular notch, is lower than the vertebra prominens. So from here to mid-thorax is not going to be as far as from here to mid-thorax. It's about the width of your hand, about 4 to 5 inches, okay? So find the jugular notch. 1 hand's width down should be mid-thorax, okay? Again, your hand's different than my hand, but on average, that hand's width down should be the right distance. Another good indicator is the nipples. A line between their nipples, that nipple line is roughly mid-thorax on most people. This changes if it's anybody with pendulous breasts. That's the name we give for breasts that hang down low. That obviously changes. The nipples go a lot lower if they have pendulous breasts. So you have to be considered a lot of different things, but on average, from jugular notch, a hand's width is the right distance down. And from vertebra prominens, the full spread from pinky to thumb is the right distance. And that gets us to the mid-thorax. We need to find the mid-thorax because for chest x-rays, that's where the central ray is placed. Okay, so now let's talk about the respiratory part of the system. The purpose of the respiratory system, it has one main job, and that's to exchange gases. The air in the room is the atmosphere that we're trying to exchange gases with, okay? So when you breathe in, you're trying to take some of the air in the room and bring it into your lungs. Your lungs have this property that they can bring the air in the room right up against your bloodstream, okay? And if you can bring the air in the room right next to your bloodstream, you can get oxygen from the air to move into the bloodstream and carbon dioxide from the bloodstream to move into the air. You can exchange gases between your environment out here and the internal environment of our body, okay? Now this works by simple diffusion. Do you guys know what diffusion is? Yeah, I think the medical assisting books does an okay job of that. So let me give you diffusion in a couple of different ways. Diffusion is one of those most common passive transport methods that our body uses. Diffusion works in a very simple way, right? Think about a glass of water, okay? Take a glass of water, just water, and you take a sugar cube, right? Sugar cube's here, glass of water's here. You plop the sugar cube into the water, okay? What happens to the sugar cube? It dissolves, right? The sugar cube is called a solute. The water is a solvent, okay? Now, what is dissolving, right? Dissolving is taking that sugar cube and letting it break apart, and it'll continue to break apart until the sugar spreads to equally to all areas of that glass of water, right? It'll diffuse equally to every part of that glass of water, right? Each little sugar molecule will be evenly spaced apart, okay? So now think about the respiratory system, okay? You bring in oxygen-rich air into the lungs, which are right next to the bloodstream. The bloodstream that's right in the lungs is going to be low on oxygen, okay? So you take something that's low on oxygen and you bring in a lot of oxygen nearby, okay? Oxygen, which is concentrated over here, will diffuse into the bloodstream until there's enough oxygen in the bloodstream, or until there's the same amount of oxygen in the bloodstream as there is on this side in the air that you breathed in, okay? Diffusion allows oxygen to transfer into the bloodstream because the bloodstream's low on oxygen in these circumstances. As well, the bloodstream has a higher concentration of carbon dioxide than the air does because we were building it up in our body, right? So that high carbon dioxide in the bloodstream moves across into the air that you breathed in, okay, until now the concentrations are equal, okay? And then you breathe back out, sending out that carbon dioxide back to the environment. But also, if you remember from CPR, you also send back out some oxygen to the environment because you can't take 100% of it into your bloodstream. You take a couple percent points of it, right? Remember, the air is 21% oxygen, right? And you breathe out about 15 to 17% oxygen. So you don't take it all in. You diffuse an amount into your bloodstream, and you diffuse an amount of carbon dioxide out of your bloodstream. You exchange gases with your environment, okay? And if we can continually do that, we can continually bring oxygen into the bloodstream and stay oxygenated, keep our blood oxygenated. Again, that's the purpose of our lungs, right? To oxygenate our blood. Now, most of that oxygen rides around in the hemoglobin of our red blood cells, right? Some of that oxygen exists as a blood gas, just as a gas in the blood, kind of like carbon dioxide does, right? So it's not all locked up in your blood cells, but the point is that we want to get it into the bloodstream. Okay, that's important. It's an exchange of gas. We can talk for a lot longer, but I won't. 4 divisions to the respiratory system: pharynx, trachea, bronchi, and lungs. Let's look at these a little closer in just a moment here, but just so we got it, Here's the 4 divisions shown all in one spot. The pharynx is what we would normally just call our throat. Now the pharynx has 3 parts to it: the nasopharynx, the oropharynx, and the laryngopharynx. But pharynx is the name for what you would just normally call your throat. Below your pharynx is your, for one, your pharynx is your throat, which is a common passageway for food and liquid and air, right? So because your pharynx is a common passageway, but you don't want food or liquid to go into your lungs, you have 2 separate tubes, right? You have one tube leading to your lungs and another tube leading to your stomach. The tube that is most posterior is called your esophagus, and that, of course, leads to your stomach. It is soft and floppy, a lot like your intestines are, okay? The tube that is most anterior is hard and made of cartilage, okay, cartilaginous rings, and we call that your trachea, and that leads to your lungs. So trachea is the tube that leads to the lungs, some important parts of the trachea that we'll get to in a moment. The trachea descends downward until about the mid-thorax, and then splits. We say it bifurcates into a left and a right, okay? Those left and right splits are no longer called a trachea anymore. When they split, we now call each one of them a bronchus. Bronchi plural, a bronchus is one of them, okay? The first ones, we can refer to them as primary or main stem bronchi. And we have a left and a right bronchus. Beyond that, the bronchi further split into secondary bronchi, tertiary bronchi, and then many, many, many bronchioles, okay? They split like the branches of a tree continue to split, right? Branches of a tree continue to split and end in leaves, right? Well, at the end of this respiratory tree, instead of leaves, we have tiny air sacs, okay? We'll get more into that in just a little while here, but the bronchi split, that's the point, okay? They continue to split and split and split, getting smaller and smaller and smaller as they continue to split. And there we have our lungs, okay? So bronchi lead to every area in our lungs. Okay. Should you breathe through your nose or your mouth? No. In through the nose, out through the mouth, right? You can breathe in and out through your nose if you want, but it's usually easier to go in through the nose, out through the mouth, yeah? There's an important reason for that. Our nasal passages have a lot of surface area, okay? By bringing air in through your nasal passages, you can either warm the air to bring it to body temperature or cool the air to cool it down to body temperature, depending on how hot your environment is, right? If it's 120 outside, you need to cool the air down, right? If it's 50 degrees outside, you need to warm the air up, okay? So the nasal passages have the job of bringing the air to body temperature as well as adding some moisture to the air, okay? A little bit of moisture, a little bit of humidity gets added to the air as they go through your nasal passages. So your nasopharynx is the first part after your nasal passages that the air will pass through, okay? The air then, can I zoom out? Is that big enough? Yeah, sure, why not? That's big enough. All right, so here it goes. So your nasal passages lead to your nasopharynx, which leads down to your oropharynx, which is what we normally just call our throat, which will then lead down lower to the laryngopharynx. The laryngopharynx is the part of your throat just above where trachea and esophagus split, okay? We call it the laryngopharynx because the highest portion of the trachea is called the larynx. So laryngo is taken from that name, larynx. Let's zoom in again. So this tube here is the one we're trying to discuss. Down lower here we can call this the trachea, but up at the top there's some other important things going on that are not exactly trachea. First thing, we have a lid, okay? This lid is called the epiglottis. The epiglottis is shaped like a leaf, or kind of actually like your tongue, actually. It's shaped a little like your tongue. And it's attached to a bone called the hyoid bone. If you look on, can't see it well on any of these chest x-rays, but on lateral chest x-rays and cervical spines, you can see what looks like a little horseshoe-shaped bone in people's necks. I forget, do those skeletons have it on them? No. But you can see a little horseshoe-shaped bone in people's necks, and it doesn't look like it's attached to anything. And it's because it's not attached to any other bone, okay? And so all we're seeing right now is a little like cross-section of that bone, because we're looking at a sagittal plane of the body right now, right? But that bone is shaped like a little horseshoe, like that. It's called the hyoid bone, hyoid. It attaches to the epiglottis and lets us have something for the epiglottis to, to pull on the epiglottis. But anyways, that's our epiglottis, this lid to our trachea, okay? It has the job of closing anytime we swallow food or liquid, okay? That way we don't bring in food or liquid into our trachea and down into our lungs. That's called aspiration. We do not want to be aspirating these foreign objects, food and liquid, into our lungs. The only thing we want going into our lungs is air, right? The epiglottis has the job of doing that. Now, moving down, we have our larynx. Not well shown here because we're looking at it as a cross-section, but the larynx has what you call your vocal cords that change in tenseness. They tense differently to change the pitch of your voice. They're different in different people, which is why we all have different pitched voices and different sounding voices. Okay, and you know that your voice, male or female, changed as you went through puberty. A lot of that had to do with the broadening and lengthening of the vocal cords and changing of the size of the larynx as you matured. But the larynx is your voice box. That's at the top of your trachea, just under the epiglottis. If you've ever had laryngitis, you know that you probably had trouble talking, right? It's because it was an infection of the voice box. Below that, 7 to 8 inches long, is your trachea, okay? Trachea is a hard cartilage tube, and it's hard in cartilage for a reason, okay? Because in order to breathe in, you have to suck air in, okay? And you ever tried to drink a milkshake through a big straw and have the straw collapse on you because the milkshake was too milkshakey, right? Too thick, right? If you're sucking on that big straw, right, you're lowering the air pressure inside of that straw, and if the wall of the straw isn't strong enough, the wall will just suck closed, right? The straw will just suck closed. Same thing is true for something like a trachea, okay? When you breathe in, your diaphragm drops, your lungs expand, and the pressure inside of your chest goes down, okay? Pressure outside in the world is high, the pressure inside your chest is low, so there's a low pressure environment in your trachea, and if the trachea weren't made of cartilage, it would just suck closed and collapse, okay? Trachea is made of C-shaped cartilage rings so that it can stay strong and hold itself together when we're sucking air in, when we're breathing. All right, so C-shaped cartilage rings extending downward until they bifurcate into a left and a right bronchus. That brings me now to the bronchus. So trachea extends downward. There's some other things to kind of help you get your bearings here. For one, there's the thyroid cartilage. You could feel the thyroid cartilage in your own neck. That's your Adam's apple. If you have trouble feeling it, try to swallow and you can feel your Adam's apple moving up and down, okay? But that's your, it's the laryngeal prominence of your thyroid cartilage. That's that right there that you're touching when you touch your Adam's apple. That's about the level of cervical vertebra 6, so kind of towards the bottom of the neck. The trachea extends downward into the chest till it gets to the level of roughly T4 or T5, thoracic vertebra 4 or 5, and then the trachea splits to the left and the right. We call these primary bronchi or main stem bronchi. Now, what do you notice about the left and the right bronchi? Are they the same? Are they different? If they are different, how are they different?
The right's bigger.
The right is bigger. But what do you mean bigger?
There's more lobes on the right side.
Ooh, we're not there. We're not there yet. You're getting there though. Okay, so let me just explicitly show you what the primary bronchus is. So that is the primary bronchus on the right side. That is the primary bronchus on the left side. Which one's longer? The left, okay? But the right one is fatter, okay? We can only call it a primary bronchus until it splits again, right? And the right one splits right here, okay? So this is the primary bronchus on the right. That is the primary bronchus on the left. Why in the world is the left one so long? Say it louder. Yeah, because of the heart, right? If you look at any one of these chest x-rays, you notice that the heart is just bigger on the left side, okay? There is an actual chunk taken out of the lungs, cardiac notch, so that the heart can fit, okay? Now, you know that's not exactly true, but they're making it, the heart does have to take out a spot of the lungs. It's just the lungs grew without that spot. No one took anything out, right? The point is that there's a space missing here on the left lung that the right lung has. The bronchus has to be longer to extend into the left lung than it has to be to extend into the right lung. For that reason, the left bronchus is longer, it's skinnier, okay? And if you measure the angle that it diverges at, that angle is steeper than the right one, okay? Now, consider a foreign particle, some bacteria, some liquid, something, okay? It comes down the trachea following gravity, okay? And it has a choice to go left or right. It is easier for some pathogen, some foreign particle, something that shouldn't be in the lungs, to go to the right rather than it is to go to the left, okay? The right bronchus is fatter, and it's shorter, and it doesn't diverge at quite of a steep of an angle. It kind of just continues straight downward, okay? So it is easier for things to go down the right bronchus than the left bronchus. The right bronchus goes to the right lung, and the left bronchus goes to the left lung. So it's easier for disease-causing things to go to the right lung rather than the left lung, okay? This hopefully coincides with your guys' experience of in clinicals of seeing people with lung infections. They more commonly show up on the right side than the left side. A right lung pneumonia is more common than a left lung pneumonia, okay, on the average ambulatory patient. By the way, this all changes when you deal with patients who are bedridden, who have to stay, who are non-ambulatory, because when they're laying down, things change, okay? But on normal people who are just upright, living their normal lives, right, like us, right lung infections more common than left lung infections because it's easier to go to the right than it is to the left, okay? Furthermore, once you're towards the right, once you come this way, it's easier to keep following gravity, okay? So it is harder for some pathogenic organism to go upward against gravity than it is for it to keep going downward following gravity, okay? So lung infections are more common on the right, and they're more common in the lower part of the right lung than they are in the upper part of the right lung, okay? We see more diseases happening on the lower right lobe of the lung than anywhere else. There are some minor exceptions like infections like tuberculosis because the bacteria likes oxygen and there's more oxygen up high, but on the average, pathogens like to go to the right lower lobe, right lung, lower lobe, more than they do any other spot. And if somebody aspirates something, foreign body, hearing aid battery, right, a pill, a coin, if it's a kid, right, it's more likely to go to the right lung and to the right lower lobe, to the lower lobe in the right lung. But either way, there's your bronchi. We refer to the bronchi as main stem or primary, the first ones, and every split beyond that, well, the next split beyond that we call secondary. So like, this is a secondary bronchus, that's a secondary bronchus, okay? There's our secondary, but then if you notice, like on this one splits, that's a secondary bronchus, but then it splits again, this way and that way. That's called tertiary, or third, okay? So you have primary bronchus, secondary bronchus, tertiary bronchus, bronchi. Excuse me. We only do that primary, secondary, tertiary, and then after that they get called bronchioles. Bronchiole means little bronchus. Kind of like venule or arteriole mean little vein or little artery. On a chest x-ray, you can see the trachea. The trachea is filled with air. And earlier when I was talking, I said you can see roughly 4 things on an x-ray, right? You can see gas, fat, muscle, or bone, and then metal if they have metal, right? Well, air is a gas, okay? So we can see air-filled structures on x-rays. They show up dark. So let's look at this one. This is the lateral. You can see the spine here and the softer tissues up here. Let me turn the lights down because I know this is hard to see. You see this? That is our trachea, okay? Our air-filled trachea. You know, if you're taking a chest x-ray ever, you know we have them take a big breath in, right? They fill their trachea, well, they fill their lungs, but also their trachea full of air, and we see the air-filled trachea here, okay? And it's different in density, different in darkening than the rest of the structures, okay? So some terms here. We describe darkness on an x-ray as density. So if something is very, very dark, we say it's very dense, like the background on this x-ray, very dense, right? But this abdomen below the lungs, not dense. The opposite of density is brightness, okay? So if an area is very bright, like here, underneath the lungs, the abdomen, then it's not dense, okay? If something is very, very dark, then it's not bright. Brightness and density are opposites of each other. On chest x-rays, the trachea should appear radiographically dense or dark. Okay. If you follow those bronchi down and down and down, or split and split and split, right? You get past the tertiary bronchi into what we call bronchioles. Those bronchioles continue to split until they become microscopic, okay? Here we have microscopic bronchioles, referred to as terminal bronchioles. So these will be at the ends, right? You know how a tree keeps branching and ends in a little tiny twig with a leaf on it, right? Well, these little twigs are our terminal bronchioles, okay? Terminal bronchioles, you see them kind of wrapped with something. That's smooth muscle. That is visceral muscle, kind of the same stuff as your intestines have. Those muscles can constrict or relax the bronchioles, right? If you have asthma, one of the causes of asthma is a constriction of the bronchioles, okay? Making them physically smaller on the inside because the muscles wrapped around them constrict, okay? Some medications to treat asthma relax those muscles, okay? Opening up the tubes. Anyways, terminal bronchioles are the name given to the smallest of the breathing tubes, the ones at the ends of the tree. And what would be a leaf on a tree is in the body a cluster of air sacs, okay? These air sacs have a name, they're called alveoli. These alveoli have the job of butting up right against the blood. So what's not being shown here is wrapped around and intertwined with all these alveoli are blood vessels, okay? Blood vessels that are coming from the heart to the lungs, and blood vessels that are coming back to the heart from the lungs, okay? These alveoli, of which you have a couple 100 million of them per lung, so 600-ish million in total, that's several 100 million of them. That should tell you how quite small they are air sacs. They are single layers thick of epithelium, okay? Epithelium is the same type of stuff that your skin and all of your organs are lined with, okay? It's a single layer of flat cells that butts right up against your blood vessels, okay? So again, wrapped right around these alveoli will be blood vessels, and air goes in and fills these alveoli, oxygen moves through the walls of the alveoli into the blood vessels, and carbon dioxide moves out of the blood vessels into these alveoli. This is where the transfer of oxygen is actually happening, transfer of oxygen and carbon dioxide. The actual exchange of gases is happening at the microscopic level between these alveoli and the bloodstream. So that's the microscopic level. Back to the macroscopic level now. We have a left and a right lung. Lungs are mostly airspace. The alveoli are the airspace. Okay, lungs are mostly alveoli. Okay, mostly that, with connective tissue supporting them and blood vessels intertwining the whole thing and breathing tubes going in and out. Okay, but mostly they're airspace. That's why they show up dark on a chest X-ray. Two lungs, left and right. They're different. The left lung is taller and skinnier. The left lung's tall and skinny, and it has two lobes. These are separate pieces of lung. If you took the lungs out of the body, you could separate these pieces. On the left, you have a superior lobe and an inferior lobe. If you've never heard this before, superior just means higher up, and inferior means lower down. Tall and skinny, two lobes, left side. We have to make room for the heart over here. So two lobes because we have to make room for the heart. The right side is wide and short. Left lung's tall and skinny, right lung is short and fat. So tall and skinny, short and fat. Short and fat, right side, has three lobes: superior, middle, and inferior. Top, middle, bottom. Lobe is the name for the chunk of lung. The space between those chunks are called fissures. Fissures is a name taken from geographic terminology, which means like a crack in the earth. Okay, this is a crack between the lungs. Now, not well shown here, but we can see it on these radiographs. Notice how the left lung apparently sits lower than the right lung. Right lung sits up a little higher, okay? For one, the right lung is shorter and fatter, so it's going to be shorter than the left. But the right lung sits up higher. The diaphragm on the right side does not go down quite as far because you have a major organ of your abdomen located on the right upper side of your abdomen, your liver, okay? So the right lung will always appear a little bit more elevated than the left lung, even though it's not well demonstrated here. It is a little bit. It's a little bit higher than that. We refer to the top of the lungs as the apex for just one of them, or plural is apices. So the apices of the lungs are the tops. The bottoms of the lungs are called the bases. So this is the right lung base, that's the left lung base. But if you notice, on any of these, the base is not the actual lowest point, right? The lowest point on the lungs are these little tips, these little pointy tips down here. Now I said what they were earlier, but somebody else, what are these little tips? What are the names for these little tips at the bottom? Costophrenic angles, okay? We also have cardiophrenic angles, which are these ones, close to the heart. So these little pointy ends, cardiophrenic, towards the heart. These ends, costophrenic, laterally. Close to the ribs, costophrenic. Okay, so that's your macroscopic view on the lungs: apices, bases, costophrenic angles, cardiophrenic angles. Three lobes to the right, two lobes to the left. Left is tall and skinny, right is short and fat. The lungs are also supported, wrapped in something, okay? They have a layered membrane around them. We call the membrane around the lungs the pleura. Pleura as in more than one, like plural, right? Attached to the outside of the lungs is what's called the pulmonary pleura or visceral pleura. That's the outside of the lung. It's slippery and smooth. And then attached to the inside of the inside wall of the thorax, we have what's called the parietal pleura. So a layer attached to the inside of the chest and a layer attached to the outside of the lungs. Between those layers is a space filled with mucousy, slippery stuff, okay, called the pleural space. And it's slippery because the ribs and the lung have to rub up next to each other, okay? Every time the lungs expand, they have to rub on the chest wall, right? That if there was no slippery stuff, that would be very, very painful, cause inflammatory processes, just not be very good for life, right? So we're lined with a double-walled membrane, a pleura. In the middle is the pleural space or pleural cavity. That pleural cavity can fill with air in the case of a pneumothorax. It can also fill with fluid in the case of what we call an effusion. Fluid can be blood or liquid of any kind. Okay. We've got a wrapping around. Let's see. Next thing I want to do, this might be the last thing, the last thing I'm going to get to for today. I want to talk to you about different shapes of the chest, okay? We call these we call the different ways people are shaped a body habitus. Habitus is our word for how are you shaped, okay? And there's 4 body habituses, okay? The average person, we call them stenic. Stenic with an H, so stenic. I'm gonna lisp it. Stenic people account for about half of our population. They are of average height, average musculature, so they're not bodybuilders, they're not, runway models, they're not tall, they're not short, they're the average-ish person, okay? These average people tend to have a mildly curved diaphragm. Again, the diaphragm is the muscle underneath the lungs that separates lungs from abdomen. Mildly curved diaphragm and a lung height that is not much taller than the width, but it is taller. Lungs are taller than they are wide. There's some other abdominal stuff too that I'm not going to discuss, but the purpose of this is to learn about the lungs. They have an arched diaphragm, okay? So these stenic patients, we see the diaphragm have a nice arch to it. Move to your left, hyperstenic. Your hyperstenic patients are your big people, okay? They're not typically very tall, they're typically very wide and very big, the overweight, obese, whatever you want to call it. Their lungs tend to be wider than they are tall. Okay, they're short and squat, short and wide, okay? Because they're shorter and wider, the abdominal organs tend to push up higher, okay? That causes the diaphragm to be more flat. We expect them to have shorter lungs and wider lungs. So if you had a piece of x-ray film like this and you had to decide to put it vertically or horizontally for your hyperstenic patient, you're going to put it horizontally, okay? Vertically for your taller, skinnier people, horizontally for your wider people. Hypersthenic. And that should only account for about 5% of the population. That has got to be a lie. It just is. I mean, maybe worldwide, but definitely not like United States. All right, the last 2 are your underweight people, okay? Hyposthenic and asthenic. Let's go hypo first. Hyposthenic should account for about 35% of the population. These are your tall and skinny people, okay? They are otherwise healthy, but skinny, and they don't have to be tall, but skinny, okay? Skinnier than your average person. They tend to have a very elongated lung field. It looks a lot longer than it is wide. So if you're choosing whether to orient your receptor like that or like that, you orient it vertically. They tend to have an average arch to their diaphragm similar to the stenic patient, but longer, taller lungs. Okay? Again, other abdominal changes happen, but longer, taller lungs are what I was trying to get to. Your asthenic. If sthenic means normal, asthenic means not normal. Okay? Without normal, right? A means without. Your asthenic patient will have an overly arched diaphragm, narrow lungs, but very long lungs. Okay? Accounting for about 10% of the population. So, people change in the way that where their organs are located, depending on these on their body habitus. Okay? And there's roughly 4 of these body habitus. Okay. So if I said the one on the left was stenic, what would you call the one on the right?
Hyperstenic?
Not hyper. Hyper means, though, their lungs will be wider than they are tall. And if you just look at those lungs, look taller than they are wide. Right? And they're definitely longer than the ones on the left, right? So what do we think? Hypostenic. So we have hypostenic, maybe sthenic, could be a little overweight, but you get the idea. Okay, so they will change depending on body shape. That will naturally lead me into next time talking about patient preparation and actually performing the exam, which is our subject for next class positioning. So we're going to call it a good day, okay? You guys, I encourage you to review this stuff, and I'm going to add on to it next time, okay? I have a little bit more